Hello, I'm Keith Dahlhauser. I'm doing an extracapsular cataract surgery, small incision, extra cap, making a radial incision and then undermining with a blunt dissection underneath the conjunctiva and tenons and then dissecting it at the limbus. If I'm lucky, I can do just one radial cut on one side and then kind of gape the conjunctiva back, and that gives me enough exposure. We have a hot temp cautery when we go on mission trips, which we got to be careful not to burn through the sclera. I have an eraser tip cautery here in the United States I'm using, so it's a lot more convenient. We have low temp cauteries too. The bottom line is just not to burn the tissue. So we have to either keep it a little bit wet or hold it further away from the sclera or move fast when you touch it so as not to thin out the sclera. I'm putting a viscoelastic on the eye. I have a little extra, and that's just to keep the cornea wet so that my technician doesn't have to constantly squirt. I usually dab the fornix with a Rexel sponge to try to see if I can get any extra mucus material removed before the case, and then we also have to appropriately drape the eyelashes out of the way. So I have an angle crescent blade. I'm using it making a linear or perhaps a frown incision in the sclera about 1 millimeter back from the limbus. It's further back on the sides if you're keeping a straight line, if you will. If you don't have an angle crescent, then you can have a straight crescent, keep it straight at this step, and then you can bend it to tunnel forward. So this is a held upside down crescent. I'm trying to do about 50% depth in this sclera, trying to do it all in one pass if I could. And then making a little bit deeper on this side because it felt a little shallow, and then flipping the crescent straight. I'm making a thick lip there so I have a little extra tissue there so it doesn't rip if I'm stretching the wound. So I try to make it a little bit thicker right at the wound, and then as I tunnel forward, then I think about trying to stay thin so I don't prematurely enter. If you prematurely enter, then you can just back up and then go over the top of it at a more shallow depth, and ideally the tissue doesn't prolapse through. I'm going wide on the inside, trying to stay in the same path. When I cut to the sides, I have to tip the left side down when I cut left and the right side down when I cut right. The inside of the wound I'm trying to make wider than the outside of the wound. And it's kind of a side-to-side wiggle to make it tunnel forward. And I want to be up in the cornea about a millimeter there, making sure it's all in the same plane. The blood sometimes is nice because it helps to identify where your wound is. And then we switch out to a keratome. The keratome, we want to make sure that we maintain the same plane of the wound. So no resistance, the tip goes all the way up, level out, and then enter the eye. Then we have trypan blue. So staining the capsule makes it a lot easier to identify when we're opening it. I just have air in the syringe first, so the air goes in first and then the blue comes next. And then kind of painting the anterior capsule with the side of the cannula to make sure it gets everywhere. And then rinsing out the blue with BSS so it's not toxic and so we can see things better. And then a viscoelastic. I have a dispersive in the States and a cohesive. I'm using the dispersive here. And then our paracentesis, we have one on the right, one on the left. We want to make sure that the wound for the paracentesis is larger than you would normally do for a phacoemulsification. We have to be able to get the Simcoe to go in and out. Sometimes in the early stages you could take the Simcoe and just put it in the wound to make sure it is the right size. We want to make sure this doesn't connect with our tunneled forward wound. So our scleral wound and the paracentesis, we don't want connecting there, if you will. So I got those in while I have viscoelastic in. It's nice to have it as wide as I need right here. If we try to widen it later when I need it, it'll be difficult because it won't have viscoelastic in there protecting. I use a cystotome in my normal phaco emulsification in the United States. So this would be the same for me, except I'm going a lot wider here. So I'm trying to go out as far to the edge of the iris as I can go. You'll see later on that I could have been a little bit wider. This lens had a hard time coming up through a continuous tear. So if it's a really big continuous tear, then just trying to use it makes sense. If it's a little smaller than we think would work, then we can put relaxing incisions in the anterior capsule. Multiple 6 different cuts in the anterior capsule all around. So then it's kind of like a can opener, but then you get some of the advantages of having the edge of a continuous tear. So I wasn't as wide as I liked, so I deepened a little bit more with viscoelastic, and then I'm switching out from a Utrata forceps. I usually like to remove the stained anterior capsule so that I don't confuse it with decimase if something's not looking nice during the case. And then at this stage we would hydrodissect, but before we hydrodissect, I like to open the wound. So I put viscoelastic in to deepen so that I can now cut with a blade and not hit the iris. So I'm opening the wound to its full extent now before we hydrodissect, because if the lens pops forward, I want to be able to just go in and take it out. So, and I also need to make sure that I'm in the same plane, so it has a little resistance. It's not easily going in, so I'm not forcing it in. I'm not creating a new plane. I'm moving side to side, making sure I have the right angle with the tip up so that I am in the same plane. It should be a smooth, easy enter, like right there. So now I'm cutting sideways, going wider on the inside than I do the outside. If the lens is too big to get out, it's usually the inside right there, so trying to get as wide as you can on the inside. So now with the wound wide open, we can do our hydrodissection. I think about this first hydrodissection as similar to phaco, so I want to loosen up the lens, make sure I get a posterior fluid wave, make sure I don't have any adhesions between the capsule and the lens. So I'm just trying to get mobility of the lens. I'm not really thinking about popping it up yet. If I'm unsure if it's loose, then I can rotate it. Once I feel it is free from all the capsule adhesions, then I start getting more aggressive with my hydrodissection and rotations. So a rotation sometimes will pop up one corner. If I'm pushing down on one side right there, the left side should pop up, but it didn't. Other ways to pop it up is I could take a cystotome and put it on the center of the nucleus and rock it away, and then that would help pop up the lens under the wound. I frequently go around the equator right about there to see if I can get the edge of the lens to lift. Usually an aggressive rotation and pushing down like that gets one side to pop up. It looks like it wants to, but it's just not coming anterior to that stained anterior capsule. It's nice that we can see the blue on the anterior capsule because we can see where the edge of the lens is. So I'm getting a little more aggressive than I normally want to be, trying to get the edge to come up above the blue. It's still not above it yet. And there, I finally got it up. Almost, still not above the blue. You can see the blue anterior to the lens. The take-home point for this is I should have put relaxation incisions in the anterior capsule to not struggle this much. I was lucky to not damage tissue by rotating it so aggressively. So once I get an edge lifted, then I put viscoelastic to deepen the bag underneath it and to lift up the lip so it's up at the wound. So now I'm going to go in with my lens loop underneath and a cyclodialysis spatula anterior, and then compress the lens into the lens loop and then hold it away from the cornea. The toe stays up, the heel goes down, so I'm pushing down on the wound with the heel and lifting up with the toe and taking the lens out. Now there's epinucleus in there, so that's in the wound. That might stop the wound from being self-sealing. So the first step is to kind of irrigate in the wound and burp a little bit if there is a lot of epinucleus to remove. Sometimes just pushing at the wound will get it out. And this didn't look too solid, so I just took it through the paracentesis. It's nice having two paracentesis to be able to get the cortex from different angles. In my right hand is the Simcoe. In my left hand is a 10 cc syringe. The 10 cc syringe, when we start the case, I put a cc of BSS in it and then hook up all the tubing and then irrigate that 1 cc of BSS through the 10 cc syringe through the tip of the Simcoe to get all the air out of the system. And then I'm all set to start sucking on the 10 cc. So if I don't have vacuum here, if I'm sucking on this tissue and it's not coming, then I look down at my 10 cc syringe in my hand and see if there's air in it. If there's air, then you can't create a vacuum. And so you have to find out where the air came from, which is usually a tear in the tubing. So then you'd have to trim the tubing and reattach it to the Simcoe. It's not unusual a couple times on mission trips that we have to trim tubing and reattach to Simcoes to prevent air from coming in. But frequently it's like when you suck on something and it's not coming, that's where the problem is. It's air in the system. So now I have all the cortex out. So we're ready for the lens. In our mission trips, we have solid 6.5 millimeter optic lenses. In the United States, I have a foldable MA50BM lens that I can use, but I don't fold it with an extra cap. I still go in flat. But it's a nice rescue lens for putting in the sulcus if I have a problem with phaco. So I can see the continuous tear is all intact there. So I'm going to be aiming to put the lens in the bag. I put a dollop of viscoelastic on the wheel and then put the lens on it to help lift it up so I can grab it easier. I'm using a Anglo McPherson to put it in. I get the leading haptic underneath the iris. And I have a 0.12 in my other hand to grab it if it's trying to slide out. And then the best way to get the lens in, so if you can capture it under the pupil, that's nice. Then it kind of holds itself, or in the bag. So then I put viscoelastic in so to re-deepen it. Rotation is usually the best way to put the trailing haptic in. And so that just snapped in the bag there. So take the viscoelastic out, clean up the wound a little bit, and then in the United States, if we have easy access, or even in other countries, if I put myostat in, it's helpful. Sometimes the haptics aren't going where we think they are, the view is difficult. So if we can constrict the pupil, we'll be able to see it pulling on one of the haptics, if the haptic's up in the anterior chamber, or if the haptic is incorporating the iris peripheral, it's nice to have it slip off and to have a nice round pupil. The main wound we can tell is watertight because it's been holding pressure while we do all the Simcoe work on the sides through the paracentesis. So if it wasn't holding tight, we would have had iris prolapse or fluid coming through the main wound. So I'm just hydrating my paracentesis and putting in myostat. And then we check the wound with Q-tips or Wexel sponge. Um, the conjunctiva closure, it's usually just one corner of it needs to be closed, the radialized portion. If you just put in one suture, I try to bury the knot so that it's less irritating to the patient. When I'm hydrating wounds, I'm trying to hydrate the roof more than the side. And that little thing that I touched was epi defect, a little abrasion on the epithelium that occurred. So the wound is watertight, and then we just close it with our fast absorbing gut or vicryl suture. We'll, at the end of the case, if we have moxifloxacin, we can irrigate some of that in the anterior chamber and then give an injection of a steroid antibiotic combination, subconjunctival, taking care to see the tip of the needle so that we don't puncture anything. Well, thanks for watching the case.